Today we're going to be talking about dental health. As you go through your treatment and in the maintenance setting as well. And I chose this topic, one, because you guys were asking for it. You wanted to know more about your oral health as you were going through treatment. And I found that it was something that was very overlooked. Like I can remember when I was first diagnosed and we started talking about treatments, oral health was never something that was brought up in great detail. Often you may be told, hey, you're taking a bisphosphonate and this is what you're going to have to keep an eye out for, or do all of your dental work before you start. But it's so much more that goes along with that, that's just not talked about and it's just not brought up and it's overlooked. So I wanted to make sure that we had an opportunity to kind of address some of those things that we don't know, that you just don't know what you don't know. So a lot of times we end up struggling with, the things that those therapies can leave behind, like tooth decay and dry mouth, cavities, and for some of us, the smile just may not be as bright there. So I wanted to bring in an expert to kind of talk about this and provide some info to help, the many patients that are just starting out on the journey, as well as those of us who've been on this journey for a while and who may be in like the maintenance setting and experiencing some issues that happen due to treatment there. So today we're welcoming Dr. Katherine Ciarrocca. She's a consulting provider and clinical associate professor in both the Division of Plastics, Maxillofacial, and Oral Surgery, and the department head and neck surgery and communication sciences. Dr. Ciarrocca received her DMD from the University of Pennsylvania School of Dental Medicine and her MSED from the University of Pennsylvania Graduate School of Education. She completed a post-secondary fellowship in oral medicine at the University of Pennsylvania Health System prior to coming to Duke. She is Associate Professor, Chief of Oral Medicine, and the Director of Interprofessional Education at the UNC Adams School of Dentistry. She's also spent part of her career as faculty at both the Dental College of Georgia as well as Penn Dental Medicine. She's a diplomat of the American Board of Oral Medicine and is a fellow of the UAB Geriatric Faculty Scholars Program. Her practice focuses on medically complex patients and how that complexity affects the oral cavity, including the diagnosis and management of oral complications of head and neck radiation therapy, chemotherapy, bisphosphonate treatment, solid organ transplant, bone marrow transplant, and cardiac surgery. Without further ado, Dr. Ciarrocca, the floor is yours.
Thank you so much, Valerie. Can everybody hear me okay? Hopefully. You let me know when it's okay to share. Can I go ahead and share my screen?
Yes.
We'll see how this goes. Share. Okay. And then, all right. Everybody hopefully can see. First of all, I would just like to say thank you again for having me. This is quite an honor, and really quite inspiring to be able to speak to so many people from across the country about something that is near and dear to my heart. It's a part of my everyday life and patient care. And thank you for that introduction, which is always just kind of embarrassing, but it gives you a little bit of context of how I was trained. And yes, I am a dentist by training, but I'm not a dentist in the traditional sense of dentistry. And with that being said, if I could get my slides to advance. Okay, everything was great. There we go. So my specialty of dentistry is called oral medicine. It is not a very well-known specialty. We often think of specialties of dentistry as things like orthodontics and endodontists and oral surgeons. Well, oral medicine is the specialty of dentistry that integrates medicine and dentistry. I often like to say that it's kind of the medical specialty of dentistry. With that being said, much of what we do as oral medicine specialists is very much involved in the cancer realm, simply because of all of the effects that different cancers and their treatments have on the oral cavity. So the definition of my specialty is, the oral health care for, um, there we go. All I could see was my face talking, and I didn't really care to see that. Oral health care of medically complex patients and the disorders that occur to the oral facial complex. And so basically, in so many words, it is the treatment of diseases of the oral facial complex, but it's also the treatment of oral complications of disease and its treatment. So at Duke, what we do at Duke Oral Medicine is, this is a big long list of all the different things that we do. So like dermatology of the mouth, neurology of the mouth, but I will highlight here one of the, the big parts of what we do: oral ramifications of cancer and its treatment. So things like mucositis, GVHD, osteonecrosis of the jaw, dry mouth. And then we also provide oral evaluation and clearance prior to stem cell transplants or bone marrow transplants, cancer treatment, anti-resorptive therapy. And so that gives you a flavor of what it is we do on a daily basis. So it's very easy to focus, being that I am a dentist by training, or just to think of, when you think of a dentist, you think of teeth, but it's so much more than just the mouth. It is the teeth, the dentition, but it's also the gums and the bone that hold the teeth in the mouth. It is the soft tissue that lines the mouth, the mucosa. It's the chewing system that we have, and then salivary glands and saliva or spit. And all of these things are interrelated, interconnected, but also very much affected by cancer and its treatment. So I like to show this slide that shows some of the complications just in general of cancer therapy, just cancer treatment. So you get changes to the blood cells and the immune system, you get dermatitis, you increase risk of infection. Um, Radiation affects irreversibly, head and neck radiation affects multiple areas in the mouth. We have mucositis, or inflammation of the inside of the mouth, nausea, vomiting, diarrhea, neuropathy, salivary gland dysfunction, trismus, which means inability to open wide. And then those complications can turn into secondary complications, meaning that because you can't chew well, or drink well, you're dehydrated. You might have bad taste in your mouth, which is what dysgeusia is. You may become malnourished. Your mouth may be an area that you can become infected, and it causes sepsis, and then dry mouth. And you'll notice that there are stars next to multiple of these complications, and that's because they are related to or have effects on the oral cavity. And so it is an integral part of, of your overall health. Why is the mouth in this area so susceptible? Well, if we look at cancer treatment and making it a very basic explanation, that the intent of treatment is to kill cells that are turning over rapidly, because after all, that's kind of what cancer cells do. They turn over rapidly, and they're the wrong cells that are turning over rapidly. So the problem is that many of the treatments for cancer affect cells that turn over rapidly as a normal part of their makeup. For example, the lining of the mouth. The lining of the mouth just naturally has a rapid turnover so that it can withstand chewing, etc. And so it makes sense that many of the treatments for cancer then have effects on the lining of the mouth. The mouth is also susceptible because it's actually kind of a dirty place. It's actually the dirtiest place on the body. If you are bitten by a human, versus a dog, you have to be on way broader antibiotics. It is a much more serious injury to have a human bite than another animal. Um, it is an area of the mouth that is constantly traumatized. I know we don't often think of eating as trauma or even speaking as trauma, but it is something, the mouth is the center of our body. So everything we do creates some level of trauma to that area. And then the resulting poor oral hygiene, meaning that it's not that you're doing it on purpose, but you just may not feel well enough to maintain or brush your teeth or keep your mouth clean because you're nauseous, etc. And so those things all together make the mouth extremely susceptible. Why does the mouth matter? Well, this is, when I talk about this, it matters because it is connected to the body. Somewhere along the line, it's like the mouth got disconnected from the body. And and that is just not the case. It's the beginning of our entire digestive system. Um, like I said, it's a dirty environment. So having oral issues can compromise health and quality of life, which is a big thing for me. I'm a big advocate of trying to maintain some quality of life as patients go through these treatments. But it can also, problems in the mouth can affect the ability to complete planned cancer treatment. And as we all know, cancer treatment is very prescribed. It has a very certain specific regimen. And so any break in that can ultimately lead to worse outcomes. And then, of course, problems in the mouth can lead to very serious systemic infections. And that is something that many people do not realize, that an infected tooth or a lesion that won't heal in the mouth can ultimately cause systemic problems. So I advocate every day for medically necessary oral care that takes place before, during, and after cancer treatment because it can help prevent and reduce the severity of complications. But the bottom line, it can enhance survival and improve quality of life. And so you will see this slide again, but this is my mantra. And this is how I set up this discussion today. We're going to talk about things before, during, and after cancer treatment. So we'll start off with oral evaluation before cancer treatment. Very oftentimes we are referred patients to do kind of a pre-chemotherapy, a pre-bone marrow transplant, a pre radiation treatment. The other one we see a lot of is pre-bone strengthening medication, oral evaluation, with the goal being to complete this oral care plan that eliminates or stabilizes oral disease prior to these cancer treatments. And in hopes that it reduces the number of complications, but it also prevents any sort of serious issues during treatment. What do we typically do at this pre-treatment oral evaluation? Education is huge. So a lot of what I'm saying today would be things that I say to patients when we see them prior to treatment. We talk about some of the acute complications, some of the long-term complications, and then we talk about best ways to keep the mouth clean. Um, we do a thorough exam. We do a screening X-ray. We call it a Panorex or a panoramic radiograph. If a patient's counts are good and they are in a good place, we recommend a cleaning because one of the best ways to get a mouth ready to go through treatment is to decrease the amount of bacteria that is in the mouth. And one of the best ways is by having a professional dental cleaning. And then we discuss removal of teeth that could potentially become infected or cause issues. So when we do this, it's not that we're making a list of, oh, you need a filling on this tooth or this. That is not our worry. We don't even do that kind of, like I said, I'm not a general dentist. We are looking for teeth that could turn into a potential issue during treatment. So we're looking for teeth that might need to be extracted, that are on the verge of abscessing. those types of things. And again, that oftentimes patients are not in a place where they're medically stable enough to have teeth removed, but we go into that process educated, knowing how to address things if they do uh, become a problem. Oral health during cancer treatment. So there are a lot of issues that occur in the mouth, and many of you have probably dealt with these. This can be from the direct damage to the tissues of the cancer treatment or indirect damage due to other systemic toxicities. What does that mean? Well, I'm going to focus on three things and touch on each of these briefly. Mucositis, that is probably the number one biggest oral side effect that is undesirable during cancer treatment. And it's unavoidable. There are chemotherapies that are known triggers, known causes of this, but they are great chemotherapies that help cure cancer. So it is taking the bad with the good and trying to manage those symptoms. It used to be that nausea and vomiting was the number one least desired side effect by patients for chemotherapy. And it's actually become oral mucositis has become the number one least desired side effect. Oral infections. We talked a few minutes ago about how the mouth is a dirty place. Well, we try to do everything in our power to prevent that by having that pre-treatment oral evaluation, but other means of keeping the mouth clean. And then that's very much interrelated with poor oral hygiene, meaning that there are some basic oral care principles that going into treatment or during treatment that we adopt so that patients can minimize any risks otherwise. So these are some pictures of pretty severe mucositis. And it may be hard to orient yourself. You may not be used to looking in the mouth, but this picture in the center, that is someone's uvula, which is that little thing that hangs down in your throat. So it doesn't just affect the mouth, it affects the throat. And the white aspect of this is ulcer, meaning it's a wound. And you can obviously see how red it is. So you look at this patient and you think there's no way they are swallowing food comfortably. And so oftentimes this is the reason patients are admitted to the hospital is to get support because they cannot maintain nutrition. You can also note on this picture how thick the secretions are, meaning how thick their saliva is. And we'll talk about that in a little bit as well. Over here, it's a little more subtle. This is the whole base of the tongue is an ulcer. Their lips are ulcerated. And because they have such low platelets, they get this crusting on the lips. And again, here's another bottom of the tongue, floor of mouth. This is just a very, very irritated area. And so extremely painful. And so how do we manage this? Unfortunately, there's no magic pill. There's lots of research going into the best way to manage this, but basically it still comes down to the same thing, keeping the mouth clean, oral decontamination, keeping the mouth as moist as possible, controlling that pain. And yes, very often this requires narcotics. It is extremely uncomfortable, maintaining nutrition, and then managing that oral bleeding, as we saw in that picture before. So how do we decontaminate the mouth? Well, trying to keep it clean and minimize the risk of any sort of infections. Sometimes is just as simple as um, keeping the mouth moist and making sure that those lesions, those sores that are associated with mucositis, are as clean as possible without causing further pain. Bland rinses, things, saline rinses. Some people like baking soda rinses. Some people like a mixture of saline and baking soda rinses. But I tell my patients, we are essentially, as humans, big blobs of salt water. So having a salt-based rinse in there flush and lavage those tissues is very physiologic, very soothing, oftentimes. There are many, many antimicrobial or septic rinses that can be used. The problem is most of them have alcohol in them, some sort of alcohol, because the alcohol is what kills the germs. Well, it also is not something that you care to have in an open wound, and so they're very, very painful. And so, um, I make a note here saying the reduction in pain is often associated with relieving dryness rather than any sort of mechanical effect. And that's simply, think about those tissues that are one big ulcer and then your mouth is dry. Your tissues stick together. So if you go to try to move your mouth, those tissues are stuck and they tear, and it causes further pain. And so that's why keeping the tissues moist is one of the best ways to just keep mucositis at bay, or at least a little more comfortable. There's something called magic mouthwash, which is a compounded, depending on where you are, has different ingredients. I never prescribe it, I'll be honest with you. It is, there's nothing magic about it. What is used, or what people find to be relieving in magic mouthwash, is the lidocaine, is the numbing agent. Depending on where you have it made, it can have some Benadryl in it. It can, sometimes they put an antifungal medicine in there, which is completely unnecessary if unless a patient has a fungal infection in their mouth. Um, that sometimes there's a steroid in it to manage inflammation, but again, sometimes they put a coating agent in it. And unfortunately, many of these items above this, they're on this list, also have alcohol. And so there's that initial burn, and then you get the numbing effects of the lidocaine. And so if I have someone who is using magic mouthwash for pain relief, I just give them plain old viscous lidocaine as opposed to magic mouthwash. Some of the more common oral infections we see, other than teeth and gums and things like that, candidiasis. Again, I always think that people can orient themselves, forgetting that all I do all day is look at people's mouths. But this is the soft palate, and this white cottage cheese type of coating is a fungus, Candida. We all have it. It all lives in our mouth and just hangs out there on its own and does its thing. It keeps things in balance. If the mouth gets off balance, whether it's because your mouth is severely dry or you don't have an immune system that is working properly, um, it has a chance to overgrow. And so we call it an opportunistic infection. It has the opportunity to grow, so it does. So it's a very common thing. This is also a form of candida. This is someone's upper jaw who has no teeth. And you can see this very well demarcated line. That's because it is related to their denture. And so the reason I put this slide in is because if someone has an oral yeast infection, it's important that you treat the dentures as well. You not only treat the mouth, but you treat the dentures. And then recurrent intraoral herpes. These are very small, very red and yellow lesions that are painful. They coalesce and make bigger lesions. And herpes is another thing that most people are carriers of herpes. If you've ever had a cold sore, that means you have a herpes virus that hangs out latent in your nerves. And when it has a chance to rear its ugly head because of your immune system, et cetera, it will. And this is why patients who are very immunosuppressed going through cancer treatment also are on medicines to help prevent these very infections. And now some words about oral care and hygiene during treatment. And there are some special precautions that we need to take, but we have found, and it is published, and the role of basic oral care during cancer treatment is extremely beneficial. It reduces the risk of and severity of oral complications. It allows patients, again, to make a successful completion of their cancer treatment. It prevents, eliminates, reduces oral pain. It minimizes infections. It minimizes oral issues that could then compromise nutrition. Um, it does provide an opportunity for us to educate about oral hygiene during cancer treatment. It can decrease the cost of care when there are fewer complications. It is less expensive to have medical care. But above all, it helps to improve the quality of life because of these things. So this is a big slide, and I will share these slides with you after, but I will highlight, we recommend cleaning teeth at least twice a day, if possible, after every meal, if possible. Sometimes that's really hard, especially if you're just kind of snacking. Um, an extra soft toothbrush is what we would recommend, and we also recommend putting it under hot water to soften the bristles so that it's not traumatizing any of the tissues. Gently cleaning the tongue with a toothbrush or even with gauze to help decrease anything that builds up in the tongue. If you're not eating a lot or not drinking a lot or not talking a lot, um, your tongue can become kind of coated, and that in itself kind of harbors bacteria. The other thing just to note here is if your platelets are extremely low, we do not recommend floss. We actually don't even recommend brushing. We will tell people to use gauze wrapped on a finger and just wipe the teeth. We don't want anything that might cause the gums to bleed, because if your platelets are less than 50, you are very prone to having oral bleeding or any bleeding. A lot of times nutrition is maintained with big, thick protein, high calorie, high sugar protein drinks, which are great because it can help maintain nutrition, but they're horrible for your teeth. And so keeping that in mind so that those thick liquids aren't laying on your teeth, causing further tooth decay. If you have mucositis, we recommend keeping those dentures out. If you use them to eat, give those tissues rest after you eat and make sure you rinse them. And then just some other simple things, if you do vomit, if you can rinse your mouth after, stomach acid is very detrimental to the teeth and the tissues, really. And then we try to uh, minimize any sort of other habits. As far as your mucosa, kind of going through the parts of the mouth, the lining of your mouth, it goes back to rinsing every 2 to 3 hours with salt water or baking soda, avoiding that alcohol, um, even avoiding hard, sharp, spicy, or acidic foods if you are prone to getting mucositis, because we don't want to do anything that might induce trauma to those tissues. And then keeping the mouth lubricated and moist. We'll talk a little more about that. Doing on time, about 10 minutes. So oral care after cancer treatment, this is what the survivors on the webinar today will be experiencing or may be familiar with. So dry mouth, I could do an entire probably 3-hour lecture on this. So I will try to summarize quickly, but this is a very, very common complaint. And I see multiple patients daily whose dry mouth is disrupting their life and causing all sorts of problems. These are the major functions of saliva. I'm going to talk to you more, and you're going to know more about spit than you ever thought you'd want to know, but saliva is very, very protective of our mouth. And our teeth and our mucosa. It lubricates. It actually helps keep germs at bay in the mouth. It keeps the lining of our mouth intact. And so when it's dry, it's much easier for your lining of your mouth to tear. It cleanses. I have a lot of patients who will come in and say, I get food stuck in my teeth all the time. That's because there's not enough saliva in there to wash it away. It helps keep the right pH in the mouth, so it's not too acidic. And then the big function it plays for teeth is it keeps them strong. Saliva constantly bathes our teeth in minerals. And so when you don't have enough of it, or the quality of it is not that great, your teeth are very prone to break down. And then it helps digest. It helps us taste. So a lot of times people who have, or patients who have a bad taste in their mouth or altered taste, it's because they don't have enough saliva in there to help create that barrier and help your taste buds work properly. It helps us speak and it helps us prepare and swallow food. So it is a really important liquid or fluid that you don't realize how important it is until you don't have enough of it. What causes dry mouth? I put this on just so that you can see there are many, many causes, with medications being the number one cause. Over 1,000 medications list dry mouth as a side effect. But then there are also very specific cancer-related causes to dry mouth. If you have head and neck radiation for head and neck cancer, it just zaps your salivary glands. Chemotherapy is known to cause oral dryness. If you're dehydrated, if you do not have enough fluid in you, you're supposed to make about 1 liter of saliva a day when healthy. If you're dehydrated, you don't have that reserve to make the saliva. If you're a mouth breather, if you use tobacco, and then there are autoimmune diseases also that cause oral dryness. So, what happens when your mouth is chronically dry and not addressed? You have, like I said before, the lining of your mouth is much more prone to trauma. So, this is the inside of the cheek. It's just very easy to catch the inside of the cheek when you don't have that good lubrication and you bite that area, it becomes traumatized, and then it's this vicious cycle. We talked about candida. If your mouth is dry, the balance of things goes off in your mouth and it has a chance for this fungus or yeast or thrush to overgrow. We talked a little bit about a coated tongue, very, very common complaint among dry mouth patients because there's that lack of lavage of the tongue. And so that keratin on your tongue has a chance to become sticky and overgrow. And this is what happens, which then can cause very bad breath. And so a lot of times patients will come in and that's their biggest complaint. Difficulty swallowing, frequent choking because there's not enough lubrication to get that food down. Periodontal disease is worsened when you do not have enough saliva to keep the balance in there. And then, of course, caries, which is our word for decay. And we see patients that have cavities that just grow exponentially and can involve all the teeth in the mouth. How do we manage it? We try to direct at what it is, what are the complaints that the patient has, but also to just give better quality of life, moisturize the mouth, and then prevention of any sort of side effects. So here are some of the tips and tricks. We recommend limiting alcoholic and caffeinated beverages. If you're one of those people that drinks something with caffeine all day long, know that you are going to be drier than someone who doesn't. Not using alcohol, rinses with alcohol, frequently sipping water, staying hydrated, using a humidifier at night. We have a lot of nighttime dryness complaints. And then using sugar-free salivary stimulants. What does that mean? Think you're trying to trick your salivary glands, your spit glands, into making saliva. Make them think you're eating so that saliva needs to come. So some examples of common salivary stimulants are sugar-free gum, sugar-free candy. Those are the most basic. But know that there are hundreds of products out there that are made specifically for dry mouth. And that I have no disclosures, no anything related to any of these companies. These are the products that patients come in and tell me, hey, I used this product and it was fantastic. But what we know at the end of the day, it is a very personal preference. Some people find mint flavoring caustic to a dry mouth. Some people aren't gum chewers, don't like to chew, or don't have teeth to chew gum. And so there are very many, chewing gum sucking on lozenges, sugar-free, but there are also products that actually adhere to the tissue and slowly dissolve over time. And Xylamelts is one of them. Zero Strip is a relatively new one. It's a little strip that sticks in there. And those are great for people who don't like having things floating around, or also for nighttime use to help with nighttime dryness. And then there are oral moisturizers. Think about what you do when your skin is dry and chapped. You put a moisturizer on. And so think of these that way. They're also lubricants. Some people call them salivary substitutes. I don't like to use that phrase because it's quite frankly a little gross sounding. But if you think of it as a lubricant, it's helping to keep everything lubricated. It's giving you a buffer in between your food and your tissues. And there are many, many of these, from the store brand sprays to the more expensive and prescription only products like Aquarel, which is a wonderful product. Um, biotin is a whole product line just for dry mouth. I'll be quite honest with you. The gel the gel and the liquid that's used for lubrication seems to be one of the more common ones patients use. Otherwise, it is just another product line. So it's very person specific and takes a lot of trial and error. And there are actually medications that are used that help prime your salivary glands to make more saliva so that then when they are used, they make more. And so that's how these were developed. They're developed to be taken 15 to 30 minutes prior to meals. But what we found is you can tweak that. It can be used before meals, or if nighttime is a problem, you take one at nighttime and put one of the little Xylamelts in, and you get some relief overnight. These are not without side effects. We have a lot of patients who complain about excess sweating, or some that'll have increased reflux, and some people that just find that they're not helpful. But that is something that you would have to discuss with your provider. Other important information about having a chronically dry mouth is to see your dentist regularly, to perform oral hygiene as instructed. It may not be a bad idea to supplement your fluoride use, getting a fluoride rinse, or having your dentist prescribe a prescription strength fluoride toothpaste, and then being mindful of what sugary foods and drinks that you're having to help protect those teeth. All right, osteonecrosis of the jaw. This is a big one with the multiple myeloma group, and I may go over just a tiny bit and we'll still have time for questions. So osteonecrosis of the jaw is something that's relatively new, meaning in the past 20 to 30 years, it's been something that's developed, and it is MRONJ or MRONJ, depending on how you say it. It's medication-related osteonecrosis of the jaw. What is it? It is a very rare side effect that's associated with certain medications, bone modifying agents, meaning, or you'll hear bone strengthening agents. It is a condition where there's a small area of the jawbone that has a difficult time healing from some sort of injury, or insult is sometimes used. And the area starts to break down and the bone dies. And so you'll see these areas of exposed bone in the mouth. And this is related to patients who are on bone strengthening agents, or we call them BMAs, bone modifying agents. These are medications that are used to prevent bone loss and bone weakness in certain types of diseases. Osteoporosis is one. Hypercalcemia of malignancy, meaning that there's bone breakdown, so there's extra calcium in the blood, and this is what is used to treat that. And then patients who have metastatic disease to the bone. So the patients I see that are on these are multiple myeloma patients, breast cancer with metastasis to bone, lung cancer with metastasis to bone, and prostate cancer with metastasis to bone. Those are the most common patients I see on these medications. And they're things like Actonel, Zometa, Fosamax, Boniva, Xgeva, Prolia. And they are fantastic medications. They do exactly what they're supposed to do and help incredibly with the bone, but they have this wonky effect on the jawbone that it causes it to not heal properly. Why does this happen? It's multifactorial. It is not completely understood, but what we know, it is a low risk. So it's thought to be less than 1% of patients taking IV bone modifying agents, and at least 10 times less likely for those taking these drugs by mouth or taking pills. So that's how common it is. It is not common. It's common to me because this is a whole subset of my practice. So I see tons and tons of it. What you hear about are the worst case scenarios. You know, you see patients with a small area like this of exposed bone, but the worst case scenario is it is not controlled or treated, and it's left to go crazy, and people lose a whole part of their jawbone. Those are the worst case scenarios that you hear about. And I see those patients, unfortunately. But I also see the ones that have small areas like this that we manage and follow. Oh, if I take these medications, am I automatically at risk? This is a very common question I get. Yes, you are automatically at risk, but not everybody develops it. I talked to you about that oral injury or insult that can precipitate it. So the most common oral injury or insult is having a tooth removed. So all of the literature and the research is based on the risk of this after tooth extraction. But the reality is you could also be eating a tortilla chip and gouge your gum. And when I would get a little ulcer there that would heal maybe in 7 to 10 days. You may get a little ulcer there and it takes 6 weeks to heal. So it happens because of some insult or injury, something like eating crusty bread or getting your teeth cleaned. You might have an area, but that's not to say you shouldn't do those things. You just have to be mindful and educated about it. There are certain things that are known to be associated with causing it, more likely to cause it, like tobacco use, or if you're on steroids, or if you have diabetes and you're on one of these medications. But let me reiterate, this does not mean you have a 100% chance of automatically getting it. So what are the signs of it? So I showed you some of these pictures of little areas of exposed bone. I'll be honest with you, a lot of patients will come in and say, I feel this rough area on my gum and I don't know what it is. And that's what it is. Or they'll come in and say, I have a sore on my tongue because the tongue is rubbing against the rough area of the bone. Many times it's painless, so you're not aware of it. So I encourage people to take a look around in their mouth, seek regular dental care, have someone look around and make sure it's not happening. How do we manage it? We make sure you understand that this is a risk. It is a very small risk, but it's a risk nonetheless. And so you need to know how to keep an eye out for it. Being careful about oral hygiene. What do I mean by that? We want you to keep your teeth clean and your gums healthy, but I had a patient who was using his water pick on full blast and injured his gums, and it turned into an area of osteonecrosis. And it was one of the worst cases I saw because he kept trying to clean it. So it's a balance between keeping your mouth clean and not being so aggressive that you cause some sort of injury. The other part of this, the big take home message, is that there are very easy ways to treat this. It is very conservative, and maintenance ways of managing this. Most of my patients see me about every 8 weeks, and we monitor how it's healing. If it turns into something that looks like it could be infected, we put them on antibiotics. Otherwise, you can see I have patients here. That is the biggest thing. I've seen patients that it will take, in fact, I have pictures here. Here is my gentleman who was doing a really good job with his water pick. So after this incident, I advise all my patients, yes, it's fine if you want to use a water pick, keep it on the lowest setting. Think about not causing trauma to your tissues. This is a patient who had this area of exposed bone, and you can see it's just bone. There's no real redness or anything around it. We watched this. I saw her every 8 weeks for about 15 months. And what your body does is we let the body do the healing. It grows tissue in underneath the bone, and then that area of bone essentially flakes off. We helped it flake off, and you'll see here, that's what she looked like. Now, yes, it's a little red there, but that all healed completely. And so more conservative treatment, as you can imagine, is what we want to try to do because we don't want to go in there causing more injury and problem. And then let me just touch briefly on oral GVHD, and this is only for patients who've had a bone marrow transplant. Just like you can get GVHD elsewhere on your skin and in your organs, you can get it in your mouth, and it can cause oral dryness. It can cause oral lesions that we treat with topical steroids and topical agents. Knowing that having oral GVHD does slightly increase your risk of oral cancer. And so we put people on on surveillance. So my GVHD patients, once we get it under control and comfortable, we monitor them. These are pictures of cancer. They're just other pictures of oral cancer, but this is what we try to prevent and by the better management of those lesions. So I tried to touch on every spot, everything. We didn't really talk about the chewing system, but we talked about the bone is related to the chewing system. It's more than just teeth. It's all parts of the mouth, and that interventions before, during, and after can help enhance your survival and improve your quality of life. And I totally went over, but I guess I had lots to say. And I apologize. Let me stop sharing. Um, I could talk for a long time about this, so I'd like to give people a chance to ask me questions.
No worry at all. Those were some excellent questions there. So thank you. Very awesome presentation there. It is time for Q&A. I see we had a lot of Q&A that has popped up in the box there. So we definitely, if you do have a question, feel free to raise your hand. Raise your hand in the box there so we can see you there.
Yes.
And comment in the chat box, but we'll go ahead and just get started with some of those there.
Okay. I can
Question.
see them if you want me to go through.
Yeah, you
I-
want to go?
Yeah, sure. I was told a previous webinar that we should not have deep cleaning of our teeth. Um, avoid getting, I try to avoid getting dentals as my others suffer with hygienists usually use a strong machine, but they could do it by hand. All right. So the question is, should you have deep cleanings if, and I'm assuming this is if you're on bisphosphonates? I'm not sure, but I guess the
Yes.
most important thing, yes, it's I you just don't want someone to be overly aggressive. And it goes back to that. It's a balance between keeping it clean and having the least amount of bacteria in there and then causing injury. So you need to be comfortable with your hygienist, and your hygienist also needs to be educated and know that um, going in and being overly aggressive can certainly be considered one of those injuries or insults. I would not say that everyone who's on bisphosphonates should not have a deep cleaning. I think that making sure things are clean. is just as important. Um, Next question, anyone familiar or taking pilocarpine tablets? Um, so the pilocarpine, I think that was more asking other members of the webinar, but pilocarpine, it you do have to have functioning glands for it to work. So if your glands are only functioning a little bit, this might help put you over the edge and get them functioning a little better. But a lot of times I will see patients who are just taking it 3 times a day, and that's what they do. There's no timing, rhyme, or reason. And that's why I spend that time explaining, think of it as a way to prime your spit glands to make more saliva so that you get them all primed and then you do something to encourage that saliva to be expressed. And so 15 to 30 minutes before meals will help maximize that. So the timing does matter. Pilocarpine is an older medication. There's a newer, I mean, it's been around decades, but it's called cevimeline, and it is more specific to salivary glands. And I have patients that respond better to that. So that might be something you would try instead, or talk to your provider about having that prescribed and do a trial of that. And you take it the same way. Um, see, so main infusions every 6 months. Yep, that is standard comment. Most of it, yeah, base of tongue cancer. So you have severe dry mouth. Yes. You can hopefully you humidify your CPAP. Xylitol tablets don't help, but then I would also go back to some of those oral lubricant products as well. Um, and those help to keep moisture in the mouth longer than just water. Um, how does dry mouth affect mucositis? The dryness and the lack of lubrication, I think it goes back to me saying that tissues stick together and then you move and they pull apart and you already have these uh, ulcerated tissues and it causes further ulceration. Let's see. Water pick, I do, but you need to use it in the lowest setting. And the same goes, I encourage people to floss, but don't be an aggressive flosser. Um, it doesn't take much to just get those areas to clean.
I think also
So
in regards to that, what about electric toothbrushes? Because I know a lot of people are like, well, that's the thing. Can I use an electric toothbrush? Seems to clean a little better. In addition to,
absolutely. Go ahead. Sorry, I interrupted you, Valerie.
I said, in addition to the water pick, can they
Yes.
use together or?
The thing that's great about electric toothbrushes is that they don't let you brush too hard. You just hold them and they do the brushing. Many of them will actually stop if you're trying to put too much pressure. So if you tend to be aggressive, an aggressive brusher, that would be me, a scrubber, then electric toothbrushes are a great option because it won't let you do that because you're supposed to just hold it and let it do its thing. So yes, I encourage patients to use that. Implants, this is a great question. Implants and bone grafts. They are safe for myeloma patients as long as you've not been on a bone modifying agent. Otherwise, the surgery itself to place the implant or the graft is considered enough of an injury that it would not heal. And so it is absolutely contraindicated or not recommended to have implants if you've been on those bone modifying agents.
Mhm.
How do we find an oral health doctor who does what I do? So this is a great question too, and I'm going to see if I can put in here, and I'm thinking DC, Baltimore area. All right. Well, I'll do that at the end. Let me try to get these questions. But what I would recommend is go to our academy, American Academy of Oral Medicine, and they have like a find a doctor part. Find the diplomates, the board certified oral medicine specialists. Um, Food gets stuck in my teeth. Can you floss several times a day? Absolutely. You can floss as many times as you want, as long as you're not doing it too aggressively. So if there's, and that's very common with dry mouth. It's just a whole lot easier to get food stuck. Um, I mentioned antibiotics. Is there one specific antibiotic used for dental issues? Um, so that's a really good question. There are the only time I prescribe antibiotics is if there's a sign of infection. So that's a really important thing. It would seem like, oh, if you could just be on antibiotics, it would keep the bacteria at bay. That's not how we use antibiotics. We use them if you have an abscess, you're put on antibiotics. Usually something like augmentin is the first line treatment for that, because it covers a broad array of bacteria. But it's also the same thing if you have an area of necrosis in your jaw that becomes infected and you see pus there. We do a 2 to 3 week course of antibiotics. Some people who have severe osteonecrosis have to be on IV antibiotics, but there are certain antibiotics that can cause a lot of side effects too. So that's why it's really important that they're only used when there's an actual infection. Is necrosis a risk if Zometa was stopped 2 years ago after a few infusions? So that's also a great question. The thing about these medications that is tough, these bone modifying medications, is they have different lengths of time they stay in your body. Some of them stay in your body, the metabolites of them, it's 10 years. And so it's really important that your providers are working together and communicating about this, and that your oral surgeon or your dentist who's planning to do this surgery has a good understanding. There was this concept of a drug holiday. Well, take them off the medication for a few months and it'll decrease their risk. There's absolutely no good scientific literature out there that says that is the case. So a lot of times it's more, especially if you're actively being treated, it's more risky for you to be off that medication because it's not controlling your disease, your bone disease, just to have, some dental treatment. So I am not a proponent, based on all the guidelines and the evidence that's published, I am not a proponent of stopping the medication so that you can have dental treatment. And then again, making the point that many of them have active metabolites that stay in your system for 10+ years, even if you stop the medication. So, my specialist took me off, but the oral specialist said I could stay on it. Benefits outweigh. Oh, I'm loving this. Whoever wrote this, Scott. Benefits outweighed the risk since the osteonecrosis was a small white spot on my gum. Would taking the tablet form be an acceptable? Now, I can't answer that question. Your physician, hematologist, oncologist is going to prescribe you the best medication for your bones. So I can't say that taking a pill form is necessarily better or worse than an IV form. But what I will say is that if you've already had the IV treatment, it's going to stay in your system longer. And osseous surgery, I'm not quite sure specifically what you mean by osseous surgery while on Zometa. Um, you know, and I can't really answer that because there's all different osseous surgeries. Unfortunately, sorry. If peroxide works, helping with sores, and it is okay to use, keep in mind, doctors are, yeah. So peroxide can be pretty caustic to the mouth. It does kill bacteria, kill germs, but I think that it's more irritating than helpful when you have oral sores. I am, going back to that salt water and comment that we're big blobs of salt water and it's the most soothing. Um, the half-life of Zometa, I would have to not off the top of my head. Um, but that's deep cleaning. Should the hygienist use a machine or whatever is the gentlest? All right, boy, you guys have tons of um, I would
Mm.
say for deep cleaning, your hygienist should use whatever he or she can do the gentlest, but does its job. Post ortho retainers. I think retainers are fine. I don't think there's any issue with that.
Doctor,
Any other questions?
what about there was one question in there about like they take a daily aspirin or if somebody is taking a blood thinner,
Yes.
does that add to bleeding gums during a cleaning procedure?
It does. I mean, you're definitely going to be a little more oozy during a cleaning. You probably would notice it more um, a few hours after. You'll just notice that you ooze a little more because it affects that part of the clotting process. But there's no risk in you having a cleaning because you're on blood thinners like
Mhm.
Eliquis and those types of things. You just, any sort, if you're on Coumadin and it's something that's very monitored, you need to be in a therapeutic range. But yeah, I missed that question.
And it's
Um,
follow up to that as well, Dr. Ciarrocca. Can myeloma cause deeper gum pockets?
hmm. Not not that I am aware of. I will tell you the things I see most with as far as changes in the mouth from myeloma patients is when we do that screening X-ray. I will often see myeloma lesions in the jaw, just
Mhm.
like the lesions you get punched out. Lesion, we call it punched out. They're like very round circular lesions. You can get them in the jawbone as well. Um, um, that's a great question. Does aloe vera reduce mucus in the throat by rinsing with it? It, I no, it doesn't reduce mucus. So we make two kinds of saliva. We make a thin, runny saliva and a thicker, mucousy saliva. And they mix together and make kind of the perfect saliva. The thin, runny saliva is the first one to go. So you're left with this thicker, I showed that picture in there, the person with the thick um, saliva, and it gives you the feeling of it being mucousy. So what I tell people to do is to get some of these oral lubricants. They help thin out that mucus. The other thing you can do is you can actually take Mucinex if that's something that you can take, without any other issues. That helps to thin out your secretions as well. Oh,
It's good to know. Man, we could go on and on. We like the
I know. I was thinking, geez, I should have just done a whole thing on osteonecrosis. It's hard to touch on certain things. Dry mouth, like I said, I could do a whole talk on that, and I have. And there's just so many different things with it. But this has been really, really fun, and everyone is so engaged, and I appreciate it. I appreciate your time and your attention.
Thank you. Thank you for being here with us this afternoon. And if you do have questions that we weren't able to get answered, still drop them in the chat box and we will do our best to get them answered. The resources that the doctor spoke about, we'll make sure that we send those out to you in the follow-up, along with the slides that she's presented as well. So, Dr. Ciarrocca, thank you for being here with
You're welcome.
pleasure having you. And then I've just got a few outro announcements and thank everybody. Thank you for all for staying over a little bit there. I know I want to make sure that everybody has opportunity to get their questions answered there. I do encourage you, if you haven't had an opportunity, check out the Black Myeloma Health website. It's at blackmyelomahealth.org. And I invite you to join us next month. We will have our Black History Month roundtable event on February the 27th. And then a couple other events that's coming up that you may be interested in. Thursday, January 30th at 1 o'clock, the future of MRD testing. It's a webinar, Why It Matters for Multiple Myeloma Patients and What Comes Next. And on Tuesday, February the 4th at 1 o'clock is the bi-monthly blood cancer financial Q&A. You'll get expert answers to your treatment cost and support questions. The link to sign up to any of those events and even more that I haven't mentioned today is found at the bottom of this slide and will be sent to you in that follow-up email that I did mention there. As always, I want to thank our sponsors, without whom this would not have been possible: BMS, Adaptive, Regeneron, GSK, AbbVie, Sanofi, Pfizer, Kite, Johnson & Johnson, and Genentech. And finally, I want to thank you for helping us build our multiple myeloma community. I've added my email to this slide, so don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate you all and hope that you enjoy the rest of your day. And I hope to see you on another webinar soon. Bye-bye.